I actually have been doing this work for quite some time, so I do have an answer. But I just want to start by thanking Carlos for pointing out the major problem with all of my research. He just did a really good job describing the issues that you have determining causal inference when you have observational data the way that I do. And so I'm not running experiments. You can't randomize kids into juvenile justice. It's unethical to think about running experiments on how to treat kids who are in foster care. And so I am sort of stuck with this problem of observational data. And what we know from, I do work on a local level. And so it's easier to make changes to policy practice on a local level than it is, say, at the state or the federal level. And by working really closely with my partners in community to understand what exactly they need to know to make their decisions, I can actually have like small incremental wins in terms of my research. So, the people I'm working with on the ground, like, the superintendent of the county office of education, they're making these decisions anyway, right? They're gonna make the decision about what program to operate, whether they have my data or not. And so if I'm able to say, you know what, I did an analysis that looked at the last 10 years, and what I found was you're serving the kids you're trying to serve in this program, you're not serving the kids you're trying to serve in this program, that might be enough information for them to think about how they're going to allocate their resources, even if I'm not able to make a causal argument about the program's effectiveness. They're going to make that decision anyway, and I'm there to sort of say, what little piece of information can I provide you from your own data that you're not analyzing yourself that I can help you with that process.
I think maybe I was being a little bit too harsh, but in a lot of contexts, you can do a really good study and come up with some evidence in favor or against some treatment. And the problem is that there's a huge embedded population that's making a ton of money in the current regime. A good recent example is there's a knee surgery where they're not actually fixing any tendons, but they're just revising and cleaning out the knee. And a group in Texas did a really nice large RCT where they randomized people to get the surgery or to get a sham surgery at enormous cost, and estimated a pretty precise zero. So it looks like this really invasive surgery, at least people limping around for 6 months, has no long-term benefit. And despite that, we're still doing $3 billion worth of these surgeries every year. And so there's a lot of examples like that. And in some contexts, if you get in ahead of stuff, so if you're if there's some policy that we're thinking there's nobody that's already making money in a particular context, there's some possibility of setting the agenda. But once something's in place, it can be hard to move forward. So the final speaker presented a slide looking at U.S. healthcare spending, and many people agree that a good portion of that is just due to transactions costs as a function of having this really kind of scattered system. We could knock 10-15% right off the top if we went to a system like a universal payer, for example. That's very unlikely to happen in the near term, or maybe even the long term in the U.S., because there's many, many people that are making tens of billions of dollars, and they're able to turn some of that money to altering the political process. So change is very, very hard to implement when there's already people embedded that are winning and doing well.
Okay, I'll start. I'm not going to answer as a sociologist, though. So I think that in many ways my research is an extension of that concept. What I'm saying is the data that we have that are collected about our children and youth belong to our children and youth, and they should be used in service of our children and youth. And what we have is a government system that doesn't allow for, these are all underfunded agencies that aren't able to maximize the use of their data. And so because these data belong to the constituents the public, the children, their families, it's our responsibility to use it to support them in policy and practice. And so although we're not actually paying people for the use of their data, my research is in support of that philosophy, that these data are not my data, they don't belong to me, they belong to the community, and if I'm going to use them, I should be using them in ways that support the community, whether it's in helping to allocate resources or to serve students better or in whatever other way, but not paying them an actual dividend to do that.
It's a tough question. I think the data dividend idea is an interesting one, but I just don't see it as being that big a deal. I mean, your data is just not worth that much. I mean, he basically told us as much. You do a back of the envelope calculation, might be $50, $100 a year, maybe less even. In terms of the idea of that the world's changing really radically, and there's going to be a substantial fraction of our population that is incapable of producing anything anybody's willing to pay for. We have to come up with a different model. I mean, I think the idea of a universal basic income, not as a Marxist idea, but as a way of maintaining some sort of political stability, is almost a must down the road.
different pots, whether it's people not going to a hospital, or instead going to a clinic?
Very good question. I think I would go back to what Mehran said in his talk, which is it is hard to deploy a deep learning model in healthcare industry and just expect them to use it as is. I think there is a sequence of things that you need to do to have buy-in from clinicians. For example, when you're working with clinicians, you need to start with having simple rule-based model for them, explaining how it works, explaining why you understand their language, and then you can